Hello PPA members, my name is Bob Hansen. I'm excited to discuss early and late onset sepsis with my co-presenter Marissa Ross. Dr. Rice and I have no financial disclosures or conflicts of interest. The objectives of this presentation will be to ensure that at the end the listener will be able to list the risk factors for early and late onset sepsis, describe the characteristics of early and late onset sepsis, and identify the appropriate antibiotics based on likely pathogens for early and late onset sepsis. Before we begin discussing early and late onset sepsis that affects patients within the neonatal intensive care unit, I would like to take a few moments to review a few key concepts that will be important to ensure that you as a pharmacist feel comfortable understanding terminology and dosing recommendations that are found within multiple medication references. We will begin this by discussing some key terminology. Dosing of medications within the neonatal intensive care unit are often based on either weight or age. While there are advantages to either strategy, this review will focus on the use of age-based dosing terminology and describe how to use this. When utilizing age-based dosing, the first terminology that one must be familiar with is gestational age. Gestational age, often abbreviated as GA, is the time between the first day of the last menstrual cycle and the day of delivery. Postnatal age, abbreviated as PNA, is the age of the patient since delivery. And when you combine the two of gestational age and postnatal age, the total time elapsed is postmenstrual age, often abbreviated as PMA. Medication references may use PMA as the initial category to select medication dosing and frequency, and then further utilizing PNA to help guide dosing. So what does this look like in real life? Postmenstrual age, or PMA, is often used to describe the patient's progression to term gestation. Age is described in weeks and days in this example. The patient is 28 and 4, where 28 describes the age in weeks, and 4 describes the number of days the patient is. This is often described as the baby is 28 and 4. Age-directed dosing is used to account for various factors that may affect the volume of distribution of medications as well as the clearance of medications. As a general rule, the more preterm a patient is, the larger a volume distribution is, but the renal clearance of the medication is decreased. So it's important to know what constitutes prematurity. Preterm is less than 37 weeks gestational, whereas term gestation is 37 weeks and greater. While patients that are term can be further delineated based on being full term, late term, or post term, this designation does not affect dosing of medications. As I described earlier, the main reason we need to know this information is to be able to appropriately use medication references that utilize age-directed dosing. Some medication references will use weight-directed dosing, and dosing in those instances are more straightforward and will not be discussed within this presentation. Now that we have discussed the age definitions that are used, let's practice. You have a patient that is a gestational age of 26 and 3 and is now 8 days old. In this case, the patient was born after gestating for 26 weeks and 3 days and is now 8 days old. So we would have a postmenstrual age of 27 and 3. The age-directed dosing would first stratify the patient based off of postmenstrual age, which is a combination of gestational age and postnatal age. Once that is done, it further delineates the patient based on postnatal age alone. Then you're able to select the appropriate dosing, which in this case would be 4 milligrams per kilo every 36 hours. Now that we have covered terminology and dosing, let's take a few moments to discuss important screenings that happen during pregnancy that may help us decide whether or not antibiotics should be used when treating a patient with sepsis. There are several important screenings that happen during pregnancy that could cause sepsis in neonates if not appropriately treated. Most commonly is Group B strep. This often occurs between 35 and 37 weeks gestation. This is important to note the time frame, as people who deliver preterm neonates may not have been able to have this screening completed. Often Group B status of patients may not be known and therefore may affect empiric treatment. Other screenings that are completed include HIV, hepatitis B and C, chlamydia and gonorrhea, as well as syphilis. And while all these infections can result in vertical transmission to the neonate, prophylaxis or treatment of these infectious diseases will be covered in a different module. Now that we've covered the basics of terminologies and screening, let's talk about early onset sepsis. Sepsis within the neonatal period is technically defined as the sepsis that occurs within the first 28 days of life. However, in the NICU, the term neonatal sepsis is often applied to patients outside that time period. This is due to several factors, including prematurity, patient status having never left the hospital, which affects the type of bacteria that are of concern, and interventions made by the healthcare team, including placements of lines, lab draws, procedures, and mechanical ventilation. In the NICU, sepsis is broken down into two categories. The first being early onset sepsis. Early onset sepsis is defined as sepsis that occurs within the first 72 hours of life. This time is due to the likelihood that any infection is caused by a pathogen that is transmitted during the birthing process. You may also come across literature that describes early onset sepsis as the first 7 days of life. However, this time frame is reserved for term infants outside the NICU. Now that we know early onset sepsis within the NICU is defined as sepsis within the first 72 hours of life, what pathogens are we most concerned with? Early onset sepsis occurs in approximately 1.08 per 1,000 live births, and data has demonstrated that the more premature a neonate is, the more likely sepsis is to occur. This is also true for patients that weigh less than 1,500 grams at birth. Diagnostic tests that are used to identify sepsis in neonates are white blood cell counts. Both low and elevated counts can be a predictor of sepsis, as well as an I to T ratio greater than 0.2. This reflects an increase in the production of immature neutrophils and may be a positive predictive value of sepsis. Blood cultures continue to be the gold standard of diagnosis. However, a large portion of patients will be treated for culture-negative sepsis. Due to this, risk factors are also used in aid to diagnose sepsis. There are multiple risk factors that contribute to sepsis in a neonate. These include, but are not limited to, prolonged rupture membranes, which is defined as greater than or equal to 18 hours, maternal age of 19 years of age or younger, low APGAR scores defined as 0 to 3 at 5 minutes or lower, Group B colonization status being positive or unknown, prenatal antibiotic exposure, and signs and symptoms of chorioamnionitis. The most common pathogens leading to early onset sepsis are Group B strep, E. coli, and Enterococcus. Group B strep historically has been the primary pathogen of concern. However, newer literature has described that E. coli is now the most prevalent pathogen causing early onset sepsis, accounting for roughly 35.3% of all cases. Group B strep now has become the second most likely pathogen at 29.8% of cases. It's also important to note that, as we previously discussed, screening for Group B strep does not occur until the 35th to 37 weeks of gestation. Lastly, Enterococcus is our third most common pathogen, which accounts for roughly 5.5% of cases. Early onset sepsis can also be caused by less common pathogens, which include Staph aureus, Staph epi, H. flu, and Candida albicans. Lastly, Listeria is a pathogen of concern. However, it is rare. As we just discussed, the most common cause of early onset sepsis is now E. coli. The recommended antibiotic to provide coverage for the gram-negative bacteria is an aminoglycoside. Gentamicin is the most common aminoglycoside that is utilized. However, some NICUs may utilize amikacin as their preferred aminoglycoside. This is especially true in areas where the local antibiogram has demonstrated an increased level of resistance to gentamicin. When using aminoglycosides, the frequency is adjusted for the patient's renal function. While this may resemble extended interval dosing, kinetically it should be viewed as conventional dosing. In situations where meningitis is of concern, a third-generation cephalosporin should be used instead of an aminoglycoside to ensure adequate penetration into the CNS. Historically, cefotaxime has been recommended and the most studied third-generation cephalosporin. However, due to this no longer being readily available, the AAP has recommended ceftazidime as an alternative. It is important to note that routine use of third-generation cephalosporin should not be used due to risk of invasive fungal infections and resistance over time. In some NICUs, routine fungal prophylaxis may be warranted when a third-generation cephalosporin is used, especially if the NICU rate of a fungal infection is greater than 10%. Recommendations on fungal prophylaxis will be discussed later in this presentation. Having discussed the antibiotic that should be used to cover the gram negatives, we'll now discuss what antibiotic should be used to provide gram positive coverage. Gram positive coverage is provided by ampicillin. This will provide adequate coverage for the second most common pathogen, which is group B strep, as well as listeria. While listeria is rare, it is a pathogen that should still be considered when using empiric antibiotics. The guidelines for group B strep were published and updated in 2019. While the recommendations for selection of antibiotics were not significantly changed, there were updates to dosing of ampicillin. This has created some controversy over the strategy recommended within guidelines. While the guidelines have described a more simplified dosing, this has been controversial due to the lack of literature supporting the changes to the dosing. This also has reignited the debate on whether weight-based dosing or age-directed dosing should be utilized. There are advantages to both. Weight-directed dosing can account for volume and distribution. However, it does not account for renal maturation or function, and does not account for small or large weight for gestation. Age-directed dosing does account for renal maturation, and it's the most accurate and appropriate for weight for gestational age. However, this can be complicated and it can vary by source. Monitoring of safety for antibiotics used for early onset sepsis is largely focused on the aminoglycoside component of therapy. While ampicillin can lower seizure threshold when serum concentrations are elevated, routine use is generally well tolerated. Aminoglycosides should be monitored with serum concentrations and when there are decreases in renal function. Peak monitoring typically associated with efficacy can be monitored, but many NICUs have elected not to do this due to limited utility of these levels and the majority of peak serum concentrations being within the therapeutic range. Trough monitoring should be considered if therapy continues beyond 72 hours. When utilizing serum trough concentrations, it is important to remember, while often therapy is once daily, this is not based on an extended interval dosing strategy. This is conventional dosing, but accounting for the decreased renal function seen in this patient population, and thus results in it dosing just every 24 to 48 hours. This is important to note, so when obtaining a serum trough concentration, it should be measurable, unlike extended interval dosing. When evaluating renal function, it is also important to note that in this patient population, urine output is the preferred method of evaluation of renal function, as serum creatinine can be falsely elevated due to maternal serum concentrations, especially for the first several days of life. Now that we've taken some time to discuss early onset sepsis, my colleague Marissa Ross will now discuss late onset sepsis.
Conversely from early onset sepsis, late onset sepsis is diagnosed in patients older than 72 hours in the NICU or greater than 1 week old for non-NICU patients. Risk of late onset sepsis is inversely related to degree of prematurity, and neonates that are less than 1,500 grams in weight are at an increased risk of mortality associated with bacterial infections, leukopenia, and requiring inotropic support. Late onset sepsis most commonly involves coagulase negative staph epidermidis and gram negative bacteria such as E. coli. While there are some similarities for treatment when compared to early onset sepsis, the notable difference is utilizing nafcillin or vancomycin for broader gram-positive coverage. Gram-negative coverage would still be the same by utilizing an aminoglycoside like gentamicin and adding on that cephalosporin for meningitic concerns. Monitoring for safety would still be warranted based on your antibiotic selection. When utilizing vancomycin, monitoring of serum concentrations and renal function are required. Although trough monitoring was previously standard of care and still often utilized, many facilities are transitioning towards utilizing AUC to MIC ratio monitoring based on the updated IDSA guideline recommendations. With AUC monitoring, the target goal is 400 to 1. Serum concentration monitoring would follow suit as previously discussed with early onset sepsis for aminoglycosides. Urine output still is the preferred marker of renal function over serum creatinine, even with vancomycin. Now that we've learned about early and late onset sepsis, we are going to discuss another cause of sepsis in neonates, which are fungal infections. And this presentation will follow focus on treatment options for neonates with fungal infections. Neonates are also at risk for invasive fungal infections, with the most common source being the Candida species, specifically Candida albicans. 10% of hospital-acquired infections in neonates are attributed to candidiasis, with mortality rates as high as 40%. IDSA Candida guidelines do provide guidance on prophylaxis and treatment of fungal infections in several populations, including neonates. If no prophylaxis is used, treatment with fluconazole can be used with a loading dose of 25 milligrams per kilo per dose, followed by 12 milligrams per kilo per dose every 24 hours. If prophylaxis is utilized, it is recommended that treatment be with amphotericin B. While liposomal amphotericin is used in most populations due to better tolerability and less side effects, it is not appropriate in neonates due to poor penetration into the CNS and kidneys. Hornick and colleagues describe the PK and use of fluconazole in neonates. Micafungin can also be used, but should be reserved when Candida species other than albicans are isolated and need to be treated. Routine prophylaxis is not recommended in preterm neonates unless there is a high rate of invasive candidiasis greater than 10%. In that instance, fluconazole 3 to 6 milligrams per kilo per dose twice a week is recommended for 6 weeks in neonates weighing less than 1,000 grams. As previously discussed, if fluconazole prophylaxis is used, therapy should be escalated to conventional amphotericin B. And to re-emphasize the previous talking point, the recommended formulation for neonates is conventional amphotericin B. Liposomal amphotericin should not be used in our neonatal population.
Viral infections are also a concern for neonates and now will be discussed. HSV, or herpes simplex virus, tends to be the viral infection that is of highest concern in neonates, while CMV is also a concern that is covered elsewhere in these modules. HSV can occur in about 1 in 2,000 live births and is transmitted through the genital tract. The presence of lesions during labor is a clear indicator for the risk of HSV in neonates. However, maternal symptoms can be absent and HSV still be a concern. A primary infection near the time of delivery is also a concern and does create a higher risk of HSV infection in the neonate. Generally, there are 2 types of HSV infections that we see in neonates. Both are treated with the same medication. If a patient does develop HSV, the treatment of choice is acyclovir. The first type of HSV infection is disseminated disease and is very concerning. This can affect multiple organ systems, including the CNS, lungs, and liver. Localized disease is the second type of HSV infection, but largely affects the skin, eye, and mouth. It is important to note that CNS involvement can still occur even with localized disease. Oftentimes, infection with HSV must be ruled out as a source and does require specific cultures to be sent. While early onset sepsis occurs within the first 72 hours and late onset sepsis occurs after 72 hours, HSV can occur anytime after birth up to a total of 6 weeks of age, and for the most part occurs within 10 to 14 days of birth. Acyclovir should be used for both localized and disseminated disease. The recommended dose of acyclovir is 20 milligrams per kilo per dose every 8 hours. Some data has shown that neonates between the postmenstrual age of 36 to 42 weeks may need a frequency of every 6 hours. However, this is based on a PK study and not clinical outcomes, and it only should be used in patients with the postmenstrual age that are not improving. Resistance to acyclovir with HSV is extremely rare, and in treatment failures, assessment of frequency should be evaluated. The duration of treatment is based on the disease type and is typically 14 days for localized disease, while disseminated disease requires 21 days of therapy. Now that we have reviewed bacterial, fungal, and viral infections of early onset sepsis, let's review with a couple of questions. Which of the following pathogens are the most common that you will see in early and late onset sepsis? A. Group B strep, Listeria, E. coli, and Pseudomonas. B. Group B strep, Listeria, E. coli, coag-negative staph. C. Group B strep, Listeria, E. coli, MRSA. Or lastly, D. Group B strep, Listeria, and E. coli. The correct answer is B, Group B strep, Listeria, E. coli, coag-negative staph. Our next question is, which of the following are risk factors for early onset sepsis? Maternal fever, antenatal steroids, lethargy, and a 10-minute APGAR score of 9. B, maternal fever, umbilical line placement, foul-smelling fluid, membrane rupture greater than 18 hours, and an APGAR score of less than 6. C, maternal fever, umbilical line placement, foul-smelling fluid, membrane rupture greater than 18 hours, antenatal steroids, and an APGAR score greater than 6. Or lastly, D, maternal fever, foul-smelling fluids, membrane rupture greater than 18 hours, and APGAR scores of 3 and 5. In this case, our correct answer is D, maternal fever, foul-smelling fluid, membrane rupture greater than 18 hours, and an APGAR score of 3 and 5.
For question number 3, due to the presence of several risk factors, the team would like to start antibiotics for early onset sepsis. Which of the following antibiotics is the best option to recommend? Option A is nafcillin and gentamicin. Option B, vancomycin and gentamicin. Option C, ampicillin and gentamicin. Or option D, ampicillin and cefotaxime. Your answer is C, ampicillin and gentamicin. Next question asks, which of the following antibiotics is the best option to recommend for late onset sepsis? Option A is penicillin and gentamicin. Option B, vancomycin and gentamicin. Option C, ampicillin and gentamicin. Or option D, ampicillin and cefotaxime. And if you guessed B, vancomycin and gentamicin, you'd be correct. Last question to test our skills is, which of the following medications should not be used in neonates when treating invasive fungal infections? Is it A, conventional amphotericin B? Option B, liposomal amphotericin B? C, fluconazole? Or D, micafungin? Correct answer would be B. Liposomal amphotericin B is the option we would not want to use in our neonates.
A few key concepts that you should take home. Early onset sepsis should be treated with ampicillin and aminoglycosides, whereas late onset sepsis should be treated with vancomycin and aminoglycosides so that you get adequate coag-negative staph coverage. Some NICUs may be utilizing nafcillin instead of vancomycin for that coag-negative staph, but this is based off of their local antibiogram. And a third-generation cephalosporin should only be used if there's concern for CNS infections. In addition to what we just talked about, antifungal use in the NICU can include prophylaxis and treatment. Fluconazole and conventional amphotericin B are the preferred agents of use for fungal infections. And then treatment with HSV is with acyclovir. Thank you so much for listening to our talk on early and late onset sepsis, and hopefully you feel comfortable with treating both of those now.